Hypertension is a common, deadly condition that leads to stroke, heart attack, heart failure, kidney damage, and many other health problems. It's known as the silent killer because so many people with hypertension do not know they have it due to a lack of symptoms. Bloomberg Philanthropies is proud to support efforts to address hypertension and improve cardiovascular health globally, including with our partners Resolve to Save Lives and the World Health Organization. So it's my pleasure today to introduce our first speaker, Dr. Tedros Adhanom Ghebreyesus, WHO Director General. We're so thrilled to have Dr. Tedros here with us today to discuss this important issue and appreciate the WHO's leadership in this area. So please join me in welcoming Dr. Tedros.
Thank you, Annie. Your Excellency Minister Kwaku Agyeman Manu, Your Excellency Minister Terence Dayal Singh, and my good friend Mike Bloomberg, and Dr. Tom Frieden, Excellencies, dear colleagues and friends. Good morning, and thank you all for joining us today, and my thanks to Bloomberg Philanthropies and Resolve to Save Lives for their partnership on this vital issue, and especially to Mike for your continued support to WHO, all weather actually, and thank you so much indeed for your commitment to humanity. And please accept my greatest respect and appreciation. Thank you so much. More than 1/3 of deaths attributed to high blood pressure are in adults under the age of 70, mainly in low and middle-income countries. Uncontrolled hypertension can lead to heart attack, stroke, and premature death. The loss of families and communities is not only personal, it also affects economies and development. In the Sustainable Development Goals, countries have committed to reducing premature mortality from non-communicable diseases by 1/3 by 2030. To get anywhere near that target, all countries must take urgent action on hypertension as part of their journey towards universal health coverage. In fact, treatment for hypertension is so important. It's one of the 14 indicators that make up WHO's UHC index. This new report contains data on the global and national burden of hypertension and provides targeted actions to address this preventable cause of death. There are some health issues for which we lack knowledge or effective tools. Hypertension is not one of them. We have the tools. Every country can do more to use those tools to improve the diagnosis, treatment, and control of hypertension. Increasing the percentage of people whose hypertension is under control to 50% would avert 76 million deaths over the next 25 years. So it means the solution is in our hands. And we use what is in our hand, we can make significant progress. It will also save governments huge amounts in health spending. WHO estimates that investing $1 per person per year on hypertension could generate a return of up to $18. We all have a role to play. For individuals, it means healthier diets, exercise, and stopping smoking. For people with hypertension, like me, it means following your doctor's advice and taking your medication regularly. For practitioners and policymakers, it means making sure that blood pressure measurements are done on all adults seeking care at every level, and to taking a team approach to providing care for hypertension. For ministers and administrators, it means standardizing care pathways, making medication and testing equipment available, and making data collection part of routine care. WHO's HEARTS package provides this and other practical, cost-effective strategies to deliver effective hypertension prevention, detection and treatment interventions at primary care level. Currently, the HEARTS package is being adapted and implemented in over 40 countries globally. Several countries, including those represented here today, have already made bold commitments to increase service coverage for hypertension. Thank you all for your continued commitment to action against this silent killer, as Jenny said. And my thanks to Mike again and your colleagues at Bloomberg Philanthropies, and to Tom and your colleagues at Resolve to Save Lives for your invaluable partnership and support. Together, let's increase the pressure on controlling hypertension. I thank you. Gabby is asking me to acknowledge my sister. I greeted her here, but I forgot. Maybe with this crutch something is very glad to have you here, my sister. Awa Kolsek, just recognize her presence, and thank you so much for your leadership. Thank you. Okay.
Dr. Tedros, thank you for your kind words. They were deeply appreciated, although I will say you gave them exactly as I wrote them. So thank you very much. Sometimes you get a good laugh out of that, and sometimes you don't. Anyways, the week of the UN General Assembly is always about leaders of all types coming together to address the world's most pressing challenges. But one of the most urgent and critical life or death issues is also one that simply hasn't gotten enough attention. One in every 3 adults have hypertension that arrives with absolutely no symptoms. That's why it's known as the silent killer. Hypertension kills more than 10 million people every single year. And in low and middle income nations, over 40% of the deaths occur in people under the age of 70. But it doesn't have to be this way. It's one thing to lose people to cancer and diseases for which we still have no surefire cure, but deaths from hypertension are not inevitable. In fact, the vast majority of them are preventable with improved nutrition, maintaining a healthy weight, and medications that are both affordable and safe. Typically, only about 1 in 5 people living with hypertension have their blood pressure controlled, and only about 2 million of these deaths can be traced directly to excessive sodium consumption, whatever the word is, which is a leading risk factor for high blood pressure to consume. Anyways. So reducing the salt levels in our food products really is a no-brainer. In fact, in the entire field of public health, salt reduction policies are among the most cost-effective ways to increase life expectancy and reduce healthcare expenditures. Today, only 5% of the world lives in countries that have adopted best practice salt reduction policies. To help change that, however, Bloomberg Philanthropies is working with our partners in the World Health Organization and Resolve to Save Lives. And today we are releasing the first global report on hypertension from the WHO. It is a first of its kind study featuring both global and country level statistics on the consequences of uncontrolled hypertension. And it doesn't just highlight the problem, It also demonstrates how countries can prevent and address hypertension, including by improving hypertension treatments and reducing sodium in diets. The report finds, interestingly enough, that if countries mobilize to achieve the goal of reducing hypertension by 50% by the year 2050, 76 million premature deaths would be avoided. Of course, the sheer magnitude of the challenge means that no organization can solve it on its own. It's essential for governments across the world to start taking a more proactive stance on combating hypertension and its underlying causes. Not only will it save lives, it'll save countries billions of dollars every year, but more importantly, the unnecessariness of tragedy in families can be avoided. After all, every single person lost to hypertension represents a family left heartbroken and a community deprived of their talents and contributions. So I wanted to say thank you to all of you for championing this cause and for being part of the solution. It's something that we really can do something about with relatively minor cost and inconvenience. I can't think of any reason why you wouldn't want to do this other than lethargy or people don't know. Or they just don't care about each other. But we care, all of you in this room, and I want to say thank you for everything you do. And with that, let me welcome Health Secretary Dr. Ted Urbosa of the Philippines, and I'd like to thank him for joining us with his leadership. Today the floor is yours, all you.
Good morning, everyone. Dr. Tedros, Dr. Friedman, Mayor Bloomberg, Ministers of Health, distinguished guests, ladies and gentlemen, thank you for this opportunity to say a few words at the significant launching of the first global report on hypertension. Hypertension is a leading risk factor for the #1 cause of death in the Philippines. Cardiovascular disease in 2021 accounted for more than 310,000 registered deaths in the country. The prevalence of elevated blood pressure among adult Filipinos in 2021 was estimated at 18%. I'm one of those, equivalent to about 12 million Filipinos. Among those diagnosed, only 65% were aware of their condition. Treatment of those diagnosed was only 37%. And only 13% achieved optimal blood pressure control. Through the Healthy Hearts Project, the WHO, with resolve to save lives, are working together to develop models for hypertension control at local levels. We are most grateful for the financial and technical support for setting up this learning site for the rest of the country. Rest assured that all the tools and capacity building developed through the project will be cascaded throughout the country. To give an update, the project is in its phase 3. There are a number of approaches that we are taking to curb non-communicable diseases in general and hypertension in particular. These include policies on tobacco. We imposed a sin tax on tobacco that's now funding the Ministry of Health. We also are planning to impose taxes on sugar-sweetened beverages. We were planning to fund the first 1,000 Days Nutrition Project with this particular taxation. And we've just actually passed a law on trans fat removal from some of the manufactured goods, measured to fund health programs as well. However, given the magnitude of the problem, it is imperative that we diagnose every person with hypertension and make sure that every person with hypertension has access to drugs and medicines, information, and care. The Philippines implements through its PhilHealth, the Philippine Health Insurance Corporation, or the National Health Insurance, a primary care benefit package called Consulta. And it covers individual-based health services, including the initial follow-up, primary care consultation, health screening, and access to selected diagnostic services and medicines, especially the antihypertensives. The Philippines is enforcing the implementation of the Philippine Package of Essential Non-Communicable Disease Interventions, or PhilPen, on the integrated management of hypertension and diabetes for primary care health facilities. To further my country's health outcomes, we have rolled out at the Department of Health the Philippine health sector's 8-point action agenda, which emphasizes that every life is precious for strengthening our health system. The work on hypertension that has been developed with Resolve fits nicely into our overall vision of universal health care and primary health care. The report launched today is highly relevant and of great use to the Philippines, both the public and the private sector, offering a structured, organized way of controlling hypertension. Again, congratulations to the launch of the report, and I look forward to strong continuing collaborations. Thank you to the WHO, to Resolve, and to Bloomberg Philanthropies. Good morning.
Good morning, and thank you very much. The bottom line is that high blood pressure is the world's leading killer, but if countries follow WHO advice, blood pressure prevention and control could be one of humanity's greatest successes. Speaking personally, I've learned a great deal from WHO. In fact, by coincidence, exactly 30 years ago, WHO in New York City released a report declaring tuberculosis a global emergency. It focused on a disease, on the treatment, on the countries that accounted for 80% of the cases, and in the past 30 years, though deaths are still far too high, there's been a 60% decrease in the number of deaths from tuberculosis globally. That shows what's possible. Today's a big deal. It's a turning point. It's a pivotal moment for the global control of hypertension, or as the DG said, more pressure to decrease the pressure. The report shows that progress is possible. The good news really is that control and prevention are within reach. For more than half a century, treatment of high blood pressure has been standard of care in higher income countries. It's way past time for it to be standard of care for every person in the world who has this deadly condition. Hypertension care can improve primary health care, and better primary health care enables hypertension control. But we've learned that good primary health care is a necessary but not sufficient condition for control of blood pressure. The best healthcare system in the United States is a nonprofit organization called Kaiser Permanente, by far, by every measure. Until they focused on hypertension control, their control rate was only 40%. When they focused on it, implementing the essence of what the WHO Hearts strategy is, they increased that to 90%. And we're seeing that same kind of high control rate possible in countries around the world. At Resolve to Save Lives, we partner with countries and communities and organizations to implement effective hypertension control programs. We've seen that the WHO strategies work. They have 5 essential components. The first is a practical, standardized, dose-specific protocol. Note that all of the medications that are the best medicines in the world for hypertension are generic and low cost. Second, ensuring uninterrupted supply of antihypertensive medications. And with a hugely increased number of patients who need to be treated, this can be a lot of medications. Many countries can afford it, but many cannot. These medications need not cost more than a penny a pill. And if you think about hypertension, diabetes, high cholesterol, 3 medications, amlodipine, metformin, atorvastatin, a penny a pill for hundreds of millions of people who are not currently treated. Now, why can't that be available for the lowest income countries for at least a decade so that people don't have heart attacks and strokes? It wouldn't take more, just saying, than a very small proportion of pharmaceutical company profits to fund that globally. Team-based care is crucially important. Nurses, pharmacists, healthcare workers all have an essential role to play. Patient-centered services, because unless medications are free, patients may have to choose between medicines and food. And user-friendly information systems that empower healthcare providers and their systems to improve care on a regular basis. We've seen countries make dramatic progress. Places like Bangladesh, which has increased 20-fold the number of patients on treatment while doubling the quality of treatment and control rates. It's not only about treatment, it's also about prevention. Sodium reduction is neglected, but extremely important. Reducing PM2.5, reducing lead exposure, all of these can make a big difference. But even if we're wildly successful with prevention, there are 1 billion people who need treatment, and we need to do more to get to them. There's far too little funding and attention on hypertension and cardiovascular disease. It's the leading single cause of death, but accounts for less than 1% of all the global health funding. This is ethically and epidemiologically unacceptable, that 4 out of 5 people with this condition do not get adequate treatment today. We look forward to moving forward with these partnerships, and we suggest that each country look at this fundamental number, the control rate. What proportion of all people estimated to have hypertension have it under control? Only a few countries in the world have this at 50%. If the world had this at 50%, it would transform health and transform healthcare for the world. I'll leave you with one final thought. It's possible, with all of the problems in the world, to bring a fact pattern together of doom and despair. We have climate change and other environmental disasters, and they're serious. We have political polarization. We have epidemics. We have security issues and wars. We have addiction, resurgent infectious diseases, antimicrobial resistance. But there's plenty of reason to be and remain optimistic. Tobacco companies are on the run. Communities around the world are demanding good primary health care. New technology ranging from mRNA to digital solutions to clean energy can empower individuals, families, communities, and countries. For most patients, treatment of hypertension can be done with just pennies a day and is better done by a nurse than a cardiologist. It's within reach, we have to reach it. 200 years ago, no one could have imagined that tuberculosis and tetanus and typhoid would be gone from most of the world and receding in the rest. And I'm confident that heart attacks and strokes that are today's leading killers will, in the not too distant future, be as rare as those once common killers are today. So I'm delighted to welcome Dr. Bente Mikkelsen, Director of Non-Communicable Diseases in the Division of Universal Healthcare, Communicable and Non-Communicable Disease at the WHO, to share more information on the report. Bente?
Thank you very much to all of you. This is a day of celebration. It's a day of action. So if I could get my slides, it's great. So we already know, I think by now, that hypertension is a silent killer. The figures has been mentioned several times. I will mention them again because I think we really need to think hard on this. So 1.3 billion of us are affected. So it's 1 in every 3 persons. So this is not a typical disease where people don't know anybody. You know very many people. And unfortunately, some of you also are affected without knowing it. And then, globally, only 1 in 5 has hypertension under control. So let's just think about this while I'm going through some of the findings. I think it's a special occasion. This week during UNGA, we are focusing on reaching Sustainable Development Goals. We are talking about universal health coverage, and we are talking about preparedness. And we saw that treatment of hypertension were suffering during COVID. So actually, what we are discussing today will be key to all of these things discussed during UNGA. So hopefully, this will be reflected also in the discussions and the declarations. Hypertension is huge, and it's an important global health issue. And I'm very happy to say that we are so delighted to have strong partners like Resolve to Save Life and Bloomberg Philanthropy. We couldn't do this without partners, and we want more partners as well. And I'm very proud today to represent some of the findings from the report. Next slide. Yes, thank you. You gave me the slide. Thank you. So I want to remind you as well that 7 out of 10 deaths globally is from non-communicable diseases. And the biggest group of diseases is cardiovascular diseases. And again, hypertension is really the biggest risk factor for the cardiovascular diseases. And we have already heard that hypertension leads to fatality in many ways. We have ischemic heart diseases, we will have stroke, we will see fatal outcome of people living with diabetes, but also with chronic kidney diseases. Next slide, please. You will never forget that 1 in 3 actually are suffering from diabetes after this day, I think. But I want to drill a little bit deeper now, and as you can see from the screen, an estimated 46% of people with hypertension are undiagnosed, and 58% of people with hypertension are untreated, and again, only 21% is under control. This is the starting point. Next slide, please. So what we have done with a lot of support from academic partners, and I will come back to this in a little bit in a minute as well, is to show you a treatment cascade. This is important to understand the problem. So we know that the estimated global situation is very dire, both for men and women. And I know the screen is a little bit small, but it is a teaser for you to go and look at the report. So you will see that there, on the right-hand side, it's about men, and the left-hand side is women. And if you look at this, the orange spots is the untreated part of the population. And then if you move from left to right, you will see, for example, in men, that we have an untreated amount of 51%, and 11% have never received any treatment. But even for those receiving treatment, we have only 18% under control. So this is about men. The situation is a little bit better for women, but not remarkable. So if we take all of this together, again, we know that people at the age between 30 and 79 has only 21% under control. The next slide is even more granular. I will try to, again, use it as a teaser. This is about the prevalence. So the graph is arranged towards the regions of WHO. So if you go from left to right, you have the African, the Americas, the Southeast Asian, the European, the Eastern Mediterranean, and the Western Pacific. And again, if you look at the very dense colors, that's the uncontrolled hypertension, while the more sort of less dense is the controlled. So you see the same picture of controlled, uncontrolled, but you also see that the prevalence between the regions is not very different. The main differences is between the countries in each of the regions. Next slide, please. I hope that at this point you're very curious. How is my country doing? And that's what we can help you to understand better. So when you look into the report, you will see that each country has a country profile. What happens sometimes is that politicians, NGOs, whatever, they said this cannot be true. But it is the reported data from these countries. So please use them. Action based on data is probably the best we can do. When we compile this data, we have done that with WHO statisticians, and the data is from a range of sources. That's important to say. So it's NCD Risk Factor Collaboration, the Global Burden of Disease Collaborator Network, the WHO NCD Unit for Surveillance Monitoring and Reporting, and also analysis done by David Watkins and Sarah Pickergill of Washington University. Next slide, please. You could ask yourself, why are we doing this today? Isn't it known forever that we have a big problem with hypertension? And again, we are doing it because we have an opportunity to act. What is new, apart from some of the prevalence data and the country profiles, is also that we asked the question, how much illness and death would be averted if blood pressure was controlled more efficiently in all countries? And what we started off with was actually the best practice. So we estimated what would happen if the whole world was doing the same good practice as the best countries. And what you see on the screen, which has also been mentioned by several already, is that if the care of all hypertension patients are improved at the rate of the best countries, we will actually be able to avert 76 million cardiovascular deaths. 76 million cardiovascular deaths. I know these figures are difficult, but try to think about it. I'm trying to figure out what does it mean, and then I get really scared. Why are we not doing this just as we speak? So what these figures is estimates, and it's based then again on approximately 120 million non-fatal strokes, 79 million myocardial infarctions, and 70 million heart failures. And if you ask yourself, is this very costly? Well, it's an investment, and it's an investment to avert cost in the next step. And to add, we also know that there is a very high level of return of investment. So as I think it was Bloomberg saying, every international US dollar invested will have a return of 18. So this is a very good bankable suggestion. Next slide, please. We already mentioned a couple of times why we do this, and of course we focus on targets, we focus on people, we can also focus on the national economy. So this is a list of things that can be focused on. So if we have a situation as we have today with uncontrolled hypertension, we have loss of tax income, we have decreased productivity, we have major health costs. This is the starting point for real heavy burden on any healthcare system. It's also increased needs, which is generational. Next slide, please. If we look into the single family or the single person, what happens is that there is a lot of cost if the person is so lucky to even have access to medicines. Very often, it's not part of universal health coverage, so it means it has to come from its own pocket, and this is hyper expensive, and it drives poverty, and it is also then impoverishing entire families. Next slide, please. We have heard already about risk factors, and Tom Frieden was very detailed and with all the reason behind it to talk about SALT. Of course, there are other risk factors as well, and those you see on the screen is the typical risk factors that we work on when we try to modify the situation for NCDs. So all of this is important, alcohol, and to reduce the amount of alcohol, tobacco, but also air pollution, and of course, physical activity. I think more research needs to be done here to see the fragmental impact on each of these risk factors. And unfortunately, if you already have hypertension, you also very often need medication, not necessarily immediately, but you will need it. Next slide, please. So we have already heard about what WHO do, and I will mention that a couple of times as well. So already in 2016, we developed the HEARTS package, and it was done in a partnership. And as you see on the screen, and again, very difficult for you, but it covers everything. It's healthy lifestyle, it's simple protocol-based treatment, it is access to essential medicines and technology, it's risk-based assessment, and it's also monitoring, and it's guidance on how to start the whole journey to improve the system. Next slide, please. So since the inception, we have as many as 40 countries, and we have 11 partners endorsing. And we see that this is really accelerating the management in these countries. And we have seen there are examples in the report what is happening in Cuba, Philippines we already heard about, India with a big commitment made just recently, and also the hearts in Americas. And I think looking at these examples really give the hope to that this is possible. So this is my way of getting the hope in my job, is to visit these countries and see what is happening and the huge impact that we see quite immediately. Next slide shows the guideline that was developed in 2021, and it's very important, as Tom Frieden also said, because it defines a protocol based on few generic molecules. And this is the entry point for us to maybe be able, and hopefully that will happen fast, to give access to medicines and devices for people in need. So you see it's laboratory testing, it is combination therapy, target to blood pressure, the limits, of course, the frequency of assessment, the treatment also team-based. So I will conclude, and I have 2 concluding slides, so if you give me the next. Okay, 3 slides, sorry. We also brought the topic of comorbidities. Why is this important? It is important, as I think the Honorable Minister from Philippines said, you know, we have comorbidities like diabetes, like chronic kidney diseases, but also you have to look into the infectious diseases, like, for example, HIV. Why is this important? Is first of all because we are not treating diseases. We are looking at persons. They have multimorbidity. And many times we can add a small component, for example, measuring blood pressure in an HIV clinic. And we are already starting the implementation for 2 diseases at once. So then I think I have 2 slides left. So next one. So I would like to conclude. And you remember by this time now, it's 1 in 3, it's 1 in 2, because only 1 in 2 has a diagnosis, and it's 1 in 5 that has the control. Cardiovascular diseases are the leading cause of death globally. Just remember that, and please remember it when you also discuss preparedness, UHC, and whatever. The world will actually not be able to reach the SDGs unless we do something about hypertension. And I hope that the global report actually will make it clear that the time to act is now. And I will end by putting again some of the words from Dr. Tedros. And I think he said it very, very well. Strengthening hypertension control must be part of every country's journey towards universal health coverage based on well-functioning, equitable and resilient health system built on a foundation of primary health care. Thank you very much for the attention. And I would like to ask Director Gabriela Stern. She is Director for Communication at WHO.
Thanks, Bente, and I'd like to invite our 2 ministers for this panel. Come on up, please, sirs. We have the Honorable Kwaku Agyeman-Manu, Minister of Health from the Republic of Ghana. And why don't you take the seat there? And we have the Honorable Terence D.L. Singh, Minister of Health of the Republic of Trinidad and Tobago. How about in the middle? And can you hear me on my portable mic? Yes, great. And in the audience, we have Senegal Minister Awa Call Sek, and I hope you will make some comments from the floor. That would be wonderful. And this session is a discussion, a conversation to really discuss national and subnational level experience with hypertension programs, next steps, and to share what countries and governments have learned. I just want to mention the report is available, a QR code for you to scan to get the report if you don't have it already is available on cards in the room for when you exit. It is a great read and an important one. So I'm going to start by asking the minister from Ghana a question. And of course, Terence, you can jump in,
Sure.
And vice versa. So, sir, countries are facing significant shortages of healthcare workers. Can you briefly share the experience in Ghana and how you mobilize health workers and expand their scope of work to include detection and management of hypertension?
Thank you very much. The global shortage of health workforce seems to have been deepened a bit. But fortunately for us in Ghana, we're not experiencing this that much. For the past few years, we have established over 90 health training institutions that trains nurses at different levels of qualification, certificate nursing, diplomas, and things like that.
May I just interrupt for 1 second? I'm having a little trouble hearing. Are you able to hear, or is it just my old ears? I want to just make sure. It's good? Okay, then it's me.
Good.
Thank you. Excuse me for the interruption.
So we have actually produced quite a good number of nurses. We have actually done our non-communicable diseases policy. And in there, we have said to ourselves that by policy, we should establish fitness and wellness centers in all our district hospitals and the primary care levels. We put in a number of these nurses who are just concentrating in checking and making sure that we can detect hypertension at very early stages. And as part of our guidelines for diagnosis, any one person who attends a hospital routinely with whatever morbidity, whatever, disease it is, we should begin to check how your heart performs and functions. And that is helping us to do a lot of things. We have actually got an initiative we call the Heart Initiative, where together with the German group GIZ, are encouraging people to be exercising across the country. And we have ourselves and the Minister for Sports actually encourage people to create Keep Fit clubs in various communities that are working to look at some of these things. And in all these gatherings, over the weekends when people go to exercise, we send in our medical teams to be checking how people's hearts are performing and things like that. So we have actually started working, and it's like we don't seem to have much challenges with health workforce at the moment. We are rather even looking forward to export some of these nurses if we can have the space to do so. We, together with WHO, are doing what we call the labor market analysis to try to see if what we feel we have is actually practically there, to see how best we can allow some of our nurses to get out, to solve some of our challenges with employing almost all of them that we have seriously trained.
Thank you, Minister. Minister Terence, you told me to call you Terence earlier.
That's fine with
me. Call me Gabby. I wonder if you wanted to make some comments about health workers, but also I want to pose a question to you, which stems from the ministerial conference in June, where there was the Bridgetown Declaration on NCDs and mental health, and to small island developing countries share specific challenges such as remoteness and so on, and that affects the provision of care for their populations. And at the Bridgetown event, countries made commitments to scale up their national programs. How do you see this affecting programs in your country, in Trinidad and Tobago, around prevention and control of hypertension and sharing information with other small island developing countries?
So thank you very much, Gabby. Before I start, how many have heard about Trinidad and Tobago here? How many of you have been to Trinidad and Tobago? Well, we have a problem. Thank you very much, Gabby, and may I recognize Dr. Tedros and former Mayor Mike Bloomberg for their leadership. we cannot succeed without advocacy on any global issue. The issue of NCDs was placed on the front burner of the United Nations, coming out of the Port of Spain Declaration of Trinidad and Tobago in 2007, under former Prime Minister Patrick Manning of Trinidad and Tobago. And we put that on the agenda back in 2007. NCDs, Trinidad and Tobago is a hotbed for NCDs. Why? Because we have unfortunately imported an alien way of life into Trinidad and Tobago. What we eat, you walk in Trinidad and Tobago, it's like walking in New York. You see all the mega brands. The adoption of technology where children no longer play. And that has led to this explosion of NCDs. What we have done to scale up, as you rightly mentioned, is adopted the HEARTS program that Dr. Mickelson spoke about. We now have about 21,000 persons enrolled in the HEARTS program, 37% of which are now controlled. So in looking at the data, and you mentioned data, Dr. Mickelson, and Dr. Tedros mentioned 50% of persons should be controlled by 2015. It means I have 13 percentage points to go by 2050. I intend to reach there by the end of 2024. And the reason why we could do it, Dr. Mickelson, because something you said about data truth, that people don't believe data. We believe data. You have a kindred spirit in myself in believing data. And it can be done, because coming into office in 2015, we had a very high maternal mortality and infant mortality rate, and I looked at the data, and we invited PAHO in, and we achieved our SDG goals for 2030 by 2018 in terms of maternal mortality rates and infant mortality rates. Dr. Friedman spoke about amlodipine should be freely available. What we have done to scale up, Gabby, is that we have made 7 drugs freely available, including amlodipine, including nifedipine, atenolol, benzofluoroside, enalapril, lisinopril, methyl-dopa. We have made those freely available to people in our public health clinics. So that's how we scale up. And we have our primary health clinics because our focus is on primary care. I want to decrease the hospital burden and not fill hospital beds, but fill my primary care. Because a pandemic will end and your hospitals will empty with COVID cases, but NCDs are here to stay. And we can't go on filling hospitals with people with high blood pressure, diabetes, high cholesterol. So we have scaled up. The drugs are freely available. On the issue of healthcare workers, Trinidad and Tobago has a problem with healthcare workers, but not at the primary healthcare level. We have it at the level of specialties and subspecialties. So we can't get pediatric oncologists, but we can get GPs, we can get primary health physicians. The last thing I want to say, the major issue we face in Trinidad and Tobago in controlling NCDs and hypertension is not the provision of free medication. It's not the access to 109 health centers. It is the refusal by some patients to comply with their doctor's orders, to take their medications. Because we spoke about it here. They start to feel well, and then what happens? I stop taking my medication. Then I go into crisis again. Then we see you back in our accident and emergency rooms. So while Trinidad and Tobago is doing well policy-wise, we still have a problem with patient compliance. And that's the story with our HEARTS program.
Thanks, Terrence. Minister Kwaku, I was really struck by what Terrence said about imported habits, commercial determinants coming from abroad into countries and really interfering with healthy diets. I'm wondering if that is something you're seeing increasingly in Ghana, with children raised on junk food, too salty, too sugary, et cetera. And I'd be interested in your reflecting on that and how you interfere with that, or how do you get in front of it. Dr. Tedros has said that the commercial determinants of health are one of his top priorities in the coming years. And it's a hugely intractable problem, isn't it? Because it involves private sector, and it involves the notion that as you become more affluent, you get to eat these types of foods, even though they're not good for you. So,
that is correct, but not on a very huge scale. However, to our economic situation, we have a greater number of our population living in rural communities. Poverty levels are that high. And so these type of imported unhealthy foods are only taken by children from elite homes found in a few big cities in our country. The type of things that are seen here in Europe and America, foods like McDonald's and KFCs and our own versions of those type of food, junk foods, are there, but more in the cities than the rural areas. Predominantly, those of us in the rural areas continue to eat the natural foods that we were fed to bring us up, you know. But then the effect of these foods in the cities on children is very high. We are getting cases of obesity in schools, very young kids growing to the levels where they shouldn't be, you know, are there. But we do a lot of education on this. Public awareness is created. We have a large number of nurses at the primary care level. Only that some areas we don't seem to have them, but we incentivize them to move in there to do what it is. So parents are taught not to do this. We also have a program that we have started embarking upon, linking health and education, educating teachers to actually talk to young children, because we have experience of children listening more to their teachers when they ask them not to eat too much sugar, not to eat this type of food, and things like that. They listen more than even parents and health workers in clinics. So we are working on these things. The awareness is coming up. We know the harmful effects of these type of foods, and we are talking to people on this matter. We are scaling up our health promotion to try to see what we can do in that respect.
thank you.
If you allow me to briefly come in here. In Trinidad and Tobago, one of the major, we have these brands in cities, in suburban areas, and in rural areas. And that's just one brand.
Yeah.
So it's a huge problem.
And then there's the issue of physical exercise.
Correct.
Right? I'm wondering now, Minister from Senegal, Awa Kalsek, if you would like to make an intervention from the floor, no pressure, but it would be wonderful if you wanted to comment on health workforce, on packages of hypertension solutions, and so on. Thank you so much.
Thank you very much. I would like, first of all, I think that Trinidad and Tobago, we're not happy to see that a lot of people were not knowing where it is. I know that they may know also Senegal, but maybe also some don't know where it is. But it's like this. And I would like to just intervene on 2 points. The first one is that I am here as a Minister of State in Senegal to the President, but I am also member of the advisory board of Resolve to Save Life. In fact, it is why I am here. And it is why also I would like to say that I am very proud to have been involved in this issue. In Africa, we have now another problem we can say is that we have a double burden. Infectious diseases, all the diseases we know are there. But we know also that non-communicable diseases are also there. And for a Minister of Health, it's difficult to prioritize, but we have here a possibility of having interventions which has cost effective and have impact. So I think that what we say in English, I don't know it is like this, but I remember we say low-hanging fruit.
Ah, en français, c'est quoi?
Ce sont les choses. En anglais, c'est plus intéressant.
Ah, OK.
Parce que ce sont les produits qui sont vite utilisables et à moindre coût. Donc voilà.
Beautiful.
Et vous avez des résultats immédiats.
Okay.
For hypertension, I can say that this is what we have. It is possible. And when the WHO representative was saying we need to act now, for me it was yesterday. But because we didn't do that yesterday, we need to do that now. And it is very important, not only hypertension, but also all the communicable disease. I would like to inform you that we are organizing in Dakar with Gallian Forum Africa from 3 to 7 October, a very important forum where we have more community people, we have more students, but also Nobel Prize and other people, ministers. But what is important is to say that Africa is putting it, and WHO has done something recently. We have also the African Union. I think that we have it now on our agenda. And if we have some, we need to put our own effort and put our own money on that, but we need also partnership, and this will be very important. My last point is multi-sectorial approach. We cannot do that as Minister of Health. We need to do that with the other ministers, with the other people in the community. If not, it will be a vertical program again, and we will not reach the result we would like to reach. Thank you very much.
Thank you. Thank you, Minister. We have 2 minutes, and I wonder if I can ask the two of you to reflect on two things that the Minister said. One is this tension or choice. Sometimes you have to choose priorities between communicable and non-communicable. It should not be either or. It should be both and, but reality is reality. Maybe we start with that and see if we have time for the other part.
So briefly, I want to recognize my colleague from Senegal, and she's absolutely correct. You cannot distinguish between communicable and non-communicable when it comes to resource allocation. The other point that she made quite brilliantly is that it cannot be a vertical program. It has to be a horizontal and vertical program. You have to get all stakeholders involved. And lastly, I would like to invite Dr. Mickelson, because she says she wants to visit areas. I want to personally invite you in public, no pressure, to visit Trinidad and Tobago to see how the HEARTS program is going. Thank you very much.
Thank you very much. We need to give whatever priority it is to non-communicable diseases, because the extent of which it is killing people in my country, it's gradually become the #1 killer, even instead of malaria in Ghana now. So our priority is there, our attention is there. We are focusing on trying to see what we can do with three-pronged approaches: detection, management, control, right? We form partnerships with some pharmaceuticals, they're giving us things, but we have a health insurance system that has got a number of these drugs for control and management on the list. So invariably, it's like patients who are found to be hypertensive get some of these drugs free. But the same challenge with the Trinidad and Tobago as to whether prescriptions are taken fully by doctors. We get cases where some young men think that you can perform very much if you continue taking hypertensive medications and things like that. But we are working on all that by engaging people, communities, and our elderly and opinion leaders in various communities to see how best we can resolve this matter. But we are doing serious multi-sector approaches between us and the Minister for Youth and Sports for activities, us and Minister for Education, again for health promotion in schools and things like that. So that multi-sector approach is quite significant, and we have embarked on that route as well.
Thank you, Minister. And we are at time. I'd like you to join me in thanking our three ministers. And I'm going to now invite my colleague, Assistant Director General Jérôme Solomon, to come to the stage for some closing remarks. He, of course, leads the Division on Communicable and Non-Communicable Diseases. Thank you, and have a great day, everybody. Thanks.
Good morning. Dear Tom Frieden, dear Kelly Henning, Madame la Ministre d'État, Your Excellencies, honorable delegates, distinguished guests, and valued partners, dear colleagues and friends, thank you all for joining us today. We have come to the end of a milestone event launching the first ever global report on hypertension, the silent killer, and one of the leading causes of death and disability worldwide. Dr. Mikkelsen has presented the findings of the report, and I will just highlight a few here again. This new report draws attention to the enormous burden of this deadly condition in each country and worldwide. The report also shows the dramatic impact that we could have if we take action. These are some big numbers. Increasing hypertension control to 50% would prevent 76 million deaths over the next 25 years. And investing $1 per person per year on hypertension could generate a return of up to $18. But perhaps more importantly, this report provides solutions and a way forward. We have highlighted key guidance from WHO's HEARTS technical package for cardiovascular disease management in primary health care and from the guideline for the pharmacological treatment of hypertension in adults. These tools were developed to help countries make early detection, management, control, and monitoring of hypertension a part of primary healthcare services. Every country can do more in a cost-effective way. Today, we have also heard from countries, most of whom have already made bold commitments to increase service coverage for hypertension. We have heard concrete examples of how they have used interventions from the HEARTS package to scale up hypertension control. I am deeply impressed by these examples. Trinidad and Tobago, I commend you on your forward-looking efforts to scale up hypertension control. Philippines, I would love to meet a barangay health worker and congratulate them on their efforts in being the first point of contact at community level and the driving force in reaching out people with hypertension at home. Finally, today has been a renewed start, not only for WHO, but for all. Improving hypertension control is an achievable goal, and we urge you to join this call for action. Redouble our collective efforts to address this silent killer and save millions of lives. I thank you very much.
Thank you for attending. Please deposit your credentials in the receptacle.